Thank you. So we are going to be talking about a group of people who are commonly overlooked in the healthcare system, which is patients. And as systems get bigger, as things consolidate, it is harder and harder for patients to feel like they have a voice, to be advocated for. And we have two people here who are doing great work on that front. With Leapfrog Group, Leah is doing work helping to monitor quality and safety at hospitals and help people have some idea of what it is they're getting into. And also, Dr. Rosenthal has been writing for the New York Times for a long time and is now with the editor-in-chief of Kaiser Health News. Wrote a book called An American Sickness, which is... It does less than extols the virtues of the U.S. healthcare system. It's a great, great book about everything that's wrong with the system. And on that note, she has brought us a sort of example of something gone wrong. It's a feature that you're doing now on Kaiser Health News called the Bill of the Month.
I can. Let's see if I can. Well,
I think they're seeing it over there.
Are you guys seeing it? Oh, okay. Then I have to be able to see it to talk you through it. But okay, so this is our Bill of the Month. And as a journalist, I see myself as representing patients. Partly, I didn't actually set off to do this, but when I was at the New York Times, I did a series called Paying Till It Hurts, and we asked people for their stories, and we got 20,000 stories of patients. That's more than Nate Silver got on Election Day. So, and those comments and those stories are kind of a litany of all the ways in which American healthcare is failing the end user, the patient, who we now like to call the consumer. So then I wrote a book, as James said, and then I went to Kaiser Health News, where the book got more comments, and I just, I have these stories, and I feel like they need to be told, because otherwise patients don't really have much of a voice in this system, which in the end should be all about them and what they can do. So anyway, this is something I've been wanting to do for a long time, and now that I'm editing Kaiser Health News, we have a long and deep partnership with NPR, and we're working on something called Bill of the Month, where each month we ask readers to send us their bills, and we try and explicate them and understand them as best we can, which is often not very well because they don't make any sense, even though they're really big. And we try and also add on, which is really, really important for patients, a takeaway, like how you could avoid this kind of medical extortion. So I'm just going to show you, we've only been doing this for 3 months. I'll show you the first two. The third one, actually, if you listen to NPR today, it was on Morning Edition. But here are the first two. Our first one was from Houston, Texas. It was a woman named Elisabeth Moreno, who I'll just tell you a brief story, and you can see how you can really get caught out. She had some back surgery 2 months after, and of course, as often happens when you have any surgery in the US, she got a bottle of oxycodone after her surgery for pain. She took one pill, she didn't take any more than that, but at her 2-month follow-up visit, the doctor said, it's just our practice when we give people a prescription for opiates to have them pee into a cup and check for abuse. So thinking nothing of it, she peed into a cup. The screen was negative, and then she got a bill for nearly $18,000 for that urine test. This is Elisabeth in the picture. This is her father, who's a physician, who was so alarmed that his daughter had gotten this bill, talked to the lab, and without asking a whole lot of questions, said, I'll pay you $5,000 just to settle this so it doesn't go on my daughter's credit record. We ask everyone to submit their bill. Obviously, you can't, because we thought, how could peeing into a cup result in a bill of $18,000? You see it here. It was by a place called Sunset Labs. I mean, that urine was tested for everything under the sun, and tested in quantitative levels when a dipstick urine would have done. So anyway, that's how she got caught off guard, and And, you know, we were unable to figure out if the physician had a deal with Sunset Labs, which ran this test. Sunset Labs wouldn't comment. But the lesson is, when someone asks you to pee into a cup, or we're just going to send off a little blood test, you have to ask why, where it's going to be sent, and is it in my network. Oddly, since we're soliciting bills from other people, we heard from a lot of other people who said, I had the same thing happen to me with this lab or that lab. So it's not just one lab doing this. For the next month, we looked through our hundreds of submissions, and we got Ann Soloviev, who lives in D.C. She was caught out in a completely different way. She went to a dermatologist for a skin check, and the dermatologist said, oh, it looks like you might have some toenail fungus. She didn't think anything of it. She hadn't known she had toenail fungus. But the physician said, oh, don't worry, I'll call in a prescription for you. Just give me your insurance information. The prescription arrived by mail and used it. Turned out that one prescription, it was $1,500 a month, and it completely drained her health savings account without her knowing it. The pharmacy, the mail order pharmacy didn't have to tell her that they were taking that money out. No one had to tell her the price. And P.S., if you look at the FDA approvals, this is a toenail fungus medicine that only works in 6 to 9% of cases for a cure after 11 months of use. So nearly $20,000 of use for a 9% cure rate. Not a good deal. So again, we tell patients, always ask, why am I getting this toenail fungus? How much does the drug cost? You know, there are so many ways. Today's bill of the month on NPR is about a guy who got 2 CT scans 2 months apart. One was $268 and the other was $9,000. And because he has high deductible insurance, he had to pay $3,500 of that $9,000. One was in a hospital, outpatient department, and one was in an independent lab. An independent X-ray facility. So again, independent facilities, much cheaper than hospital facilities, and much cheaper also than in this area. There was one hospital conglomerate, Leah Health, that owned almost all the radiology practices, and theirs were overwhelmingly more expensive than this one independent facility. So and there you go.
Thank you. And your recommendation is that when someone gets a crazy bill like this,
there's Ann's bill for that.
Not to pay it.
Well, that sounds like a weird recommendation, but my first recommendation to people when they say, well, what should I do? My first recommendation is always, don't write the check. Because I think we're all afraid of, you know, you're going to be sent to collections, it's going to ding your credit rating, and those are real fears in this country until there's better protection, consumer protection. But I think we all have to be looking at those bills saying, first we have to be asking ahead of time so we don't get those bills, but when the bills come, you know, we have to be saying, okay, were those things done? Did I need those things? And ask why.
And maybe the first place people should go is to a journalist. Because when these things are reported, there is a funny trend where once this thing is on morning edition, sometimes the bill disappears.
Right. I mean, it's a sad commentary on our health system that the best thing you can do about an $18,000 urine bill is to go to a journalist, right? That should not be your solution. But I think in the meantime, I hope that this kind of function may shame a few providers, although shaming hasn't been very successful historically in this world. And I think it will, hopefully it will just get, my goal is to get everyone's antenna up so they will say, and it's sad, you know, you don't want to go to a physician thinking like, okay, how am I going to be ripped off today? But, you know, we have high deductible plans. This young man was a 29-year-old guy who got this really expensive CT scan, which was normal, by the way, for belly pain. And he now has a $3,500 bill that, you know, it's going to really impact his life. So,
Leah, let's talk about how cost correlates with quality. So if I was having belly pain and someone said, do you want the cheap CT scan or the expensive CT scan, and I hadn't spent a few years as a radiologist, I would probably think the expensive one because that's better and I don't want to miss anything just to be safe?
Unfortunately, if we're going to have a conversation about how these prices correlate with quality, then our conversation is now over. We have nothing to say.
All right. Well, thank you very much.
Thanks, everyone. There is zero correlation. That doesn't mean that you can't get a high-quality CT scan from a high-priced institution. Maybe you can, but maybe you can't. There's no correlation. We are accustomed as consumers to thinking that price in some way correlates with quality or kind of what you get. You know, I go to buy a toaster and I'll see 3 toasters and I think that the higher priced toaster must have a few more features than the lower priced toaster or something, and that's probably true. That's likely true. I may know nothing else about the toaster, but the pricing will tell me something. That's not true in healthcare. Pricing can be misleading. So it is, to add to the frustration of these outrageous prices that Elisabeth has so eloquently shown us, is the frustration that they have nothing to do with quality, and quality is a major problem, and it varies. And I will say something about CT scans. It varies for them too. People think they're all the same, that it's, you know, it's a CT scan, it's an X-ray or something. They're all the same. They're not all the same. Actually, studies have shown that those can vary greatly, and sometimes you can get a bad reading and a bad diagnosis that will lead you to a host of treatments that may be unnecessary or excess. So that actually is yet another layer of problem to add to this.
Okay. So you're not being a cheapskate or something if you shop around and try to find for your kid the cheapest CT scan that they can get.
You're not being a cheapskate, but you also, in the case of CT scans, there's not a lot of good quality information, unfortunately.
Yeah, that's to my next point.
There is for other things.
So that's why there are groups like yours that are trying to help people have some idea of what the quality of the product they're getting is. And one of the things you've done is create a report card type system for hospitals, giving them a grade rating like A, B, C, D, F, and I know that when that was rolled out for, in New York for restaurants, people suddenly did not want to go to a restaurant that had a sanitation rating of C, and people quickly cleaned up their act. Yeah. So you've been doing this now for a few years, rating hospitals. Have you seen any improvements or changes as a result of that?
Well, we actually designed, it's called the Hospital Safety Grade, and .org, if you want to look it up, it's all free to look up any of these grades. We designed it around what New York did and what LA did also. They did the same thing with restaurants. The nice thing about what you do in New York is you require the restaurants to post it in the window, and we can't do that with hospitals. We really want them to post the D in their, in the front of the emergency room in a big sign. Yeah. We got a D from Leapfrog for our safety, but unfortunately we can't require that. Nonetheless, we have seen major improvement in many hospitals. If they do badly on the Leapfrog Hospital Safety Grade, I will tell you, within maybe a year or two, they will have done much better. We've seen some true success stories. It does galvanize change.
Well, why can't we require them to post it? The grade. I would like to see that happen.
Okay, let's do it.
Okay.
And I was just going to say, wouldn't it be, if we want patients to be good consumers, which is the mantra now, then you go into an ER, there should be the quality grade and the price list, right?
Yeah.
I don't know that I think it's a good idea to let people, to force patients who are sick into this role, but hey, if you're going to do it, you got to give them the information. And I think, why aren't these things posted? They're considered proprietary, right? Mm-hmm. Well, no, we can't post the charge master. Oh, we don't want to post the grade. If those things had to be posted, the charge master prices would come down and the grades would go up. But it's the lack of transparency that patients, consumers, and, I would take it a step back from the patients that often I want my doctor to do that vetting, to know which of those scans is good and to give me honest information. But even the doctors often can't extract that information from the providers.
Yeah. Could you say a word just about what the charge master is, which you mentioned?
Sure. It's the master price list that every hospital keeps. Those prices are often many times, they're exorbitant, you know. We had one guy who had a 2-hour infusion, and it was charged at $120,000. And hospital CEOs will say, oh, those don't matter. But they do matter in that they are the starting point for negotiations often. They're notional, what someone called fairy tale prices. And people who are uninsured will often be asked to pay them by the hospital. So let's have those prices out there. And there's only one state, I believe, that requires disclosure of hospital charge masters, California. And all other hospitals, they're a secret. Even when they come out in, there's a malpractice case or a case that involves pricing, the hospital will tend to release a screenshot of one part of the charge master. So they're fun to look at in California because you can see how the hospital is charging, you know, $300 for a tube of bacitracin and, you know, $20 for each Tylenol, but they're shocking.
So this is an industry which is approaching 20% of our GDP, and we do not even know, people don't know how much they're paying, and prices are kind of made up. There's a lot more we could talk about. I want to go to audience questions. What is maybe one most important thing that patients should be doing differently right now before we do, from each of you?
Well, I would say look at the safety record of any place that you seek care. That's really the first thing any consumer should always do. There's major variation, and no matter what the price, no matter what the quality, you can get the best surgeon, you can get the best price for a surgery, but if you go to a place that has a bad rate of infection or a high rate of falls or injuries or accidents, it's not worth anything. It is no bargain ever. So, and there is variation, and it's a frightening amount of variation. That's the hazard of my job, is that I look at these numbers every day, and some of them are alarming at some hospitals. So you need, and that information is out there. It's not as much as it should be, but we keep pushing for it. But there is some, and that's the first thing you need to look at before you then go to the next step, which is to start to research whatever you can find on pricing and quality. Unfortunately, we have handed this problem to American consumers because the healthcare industry has not figured out how to solve its own problems. We've handed it to consumers to solve it for us. I'm sorry about that. It's a very unfortunate situation, but it is what it is.
Yeah. Well, I think we have to kind of change the passive patient model and have people, once they've looked at price, I get it when you're being rolled into emergency surgery, you can't say, wait, you know, how much is this going to cost? Or is the anesthesiologist in network? But much of what we do in healthcare is elective. You know, when your doctor sends off a blood test, you can say, what is that for? And you can say, send it to a lab that's in my network, because that will save me money. And I always tell people when they say, even when you're being rolled into emergency surgery, there's one wonderful anecdote of in my book. This woman is being rolled into emergency surgery. She's in a gown, and the practice manager comes up to her stretcher and goes, oh, we need a credit card. And she's like, you know, no clothes, no wallet. And the practice manager hands her a phone and says, can you call your husband to give us a credit card number? So, you know, we have big out-of-pocket expenses now. So I think, unfortunately, and as Leah says, it's sad to have to ask patients to do this. You got to ask those questions. We have to open up that dialogue. And physicians have to open it up too. You know, cost has been kind of like Voldemort in doctors' offices, like no one wants to talk about it. But I think we have to talk about it because it exists and our patients are paying. And you know, the other little thing I would say is I want hospitals to step up to the plate to make sure if people go to in-network hospitals, everyone who touches them during that hospitalization is in the network too. Like, I have no way to know which of the, just because this is such a common problem these days, I have no idea which anesthesiologists at New York Presbyterian, where I go, take Cigna, which is my insurance, but they do, and they should make the effort to assign those people to my case. I think it's a total cop-out to say, oh, this we don't know answer that consumers so often get in healthcare is not acceptable anymore.
And by the way, one way to address that as a consumer is to go back to your employer, if you have employer-based health insurance. I work with employers all the time, and they are constantly going to bat for employees and sometimes paying those bills when they get, an outrageous thing where they get an anesthesiologist who's out of network, and you see those bills in the 5 digits that come out of nowhere. They will help. And employers are really standing up for some of these real problems in the system.
Sort of strength in numbers effect.
Right.
Can we have a question from the audience? Maybe 2 questions? One at a time, though. It's difficult for me to see, so I'm going to trust when someone has a microphone in their hand. Okay, there.
Hi, everyone. My name is Simona. I'm here with Medisafe. We're a medication adherence platform. Thanks so much for coming in for speaking. I actually was wondering if you had given thought to bridging the gap with one of the previous panels about cultural competency and essentially cultural competency scores for hospitals, because those patient populations tend to be taken advantage of because they don't speak English, can't understand kind of what's going on. It's much easier to charge somebody who doesn't understand what the urine test is for $18,000. So have you given thought to a way where we can bring those metrics and kind of codify them the same way we can do for infection rates? Thanks.
Have you thought about that, Leah?
Well, I'll be honest. We had Leapfrog had a summit last December of all of the ratings organizations of healthcare, so like U.S. News and Consumer Reports and us and everyone. And we got taken to task for the fact that we are not accessible to diverse populations, which is true. And so we are actually working on it ourselves, but most certainly that is a big problem in the healthcare system, which we certainly need to address.
And I would say, some of it, yes, there's cultural competence that's really important, but if things are simple, they're more available and more accessible to everyone. The problem is that things are so incredibly complicated now. You need like a PhD and a coding degree to understand what's going on. I like to say, if you look, and I have one in my collection, a bill for a hip replacement in Belgium, I understand what it says even though it's in Flemish, because it's like 2 pages long and it's like 2-person camera implanted. We just need to simplify this whole thing and not require this, a PhD to navigate your lab test bill.
Yeah. We do one more?
There's someone over there.
Okay. Hi, Danny Sands from the Society for Participatory Medicine. So I love what you guys are doing and talking about. I think it's fantastic. But let me ask you both a question. So what can we do as a country to compel healthcare organizations to post and share their quality scores, their cost? And we complain about it a lot, and we've had a lot of discussions this morning so far about, helping, making consumers be better, or making patients be better consumers. But how are we going to get this information out there? I mean, you're both doing terrific work, but how are we going to change the system?
Well,
in brief,
we have started, Leapfrog for the past 15 years has been fighting to get this information out there. The fact that we have these letter grades is because CMS, which is the agency that runs Medicare, now reports data that we didn't have 15 years ago on infection rates and errors in hospitals. We didn't have it. We should have had it, of course, from the beginning, but we didn't have it. So it's been a battle, but we've gotten it published. But it is very hard. And to Elisabeth's point, one of the battles we fight is against what I would call complexity. So it's when providers come to the table with a lot of complexity about why they can't do something, why it's not good to have transparency, why things need to be risk adjusted and blah, blah, blah. There's a lot of complexity that's brought to the table about really what are fundamental arguments. I have a right to know your infection rate, but when you start to make that argument, it becomes this gibberish and wonkery, which, I mean, there's legitimacy to the wonkery, but it ends up taking over the entire debate, and in the end, people walk away with nothing. So we have tried to push past that and succeeded But we are going to have to push even more, and I think as consumers become more engaged in their own healthcare, we will have more, frankly, more leverage at that table to push past and get what we want. We're going to need more consumers engaged.
Yeah.
I think we need to wrap up there. Thank you so much to both of you. Thank you to the panelists.
Thank you.